Hi, my name is Yotimo Genetega, and I'm the founder and CEO at Gricd. Recently, we started some work with the National Primary Healthcare Development Agency, where we were able to help them track the 4.2 million doses of the Moderna vaccines being given to the Nigerian government through the COVAX facility from the United States of America. The importance of the work we were doing was to ensure that vaccines being delivered to the states were being delivered under the right conditions, and also if there were any excursions, we were going to advise each state on what the next step to take was. And basically what we were doing was we issued data loggers, real-time data loggers, which we call the modes. They are put inside each of the boxes that are being transported to every state, and then we're able to monitor each of the boxes in an entire batch as they're being transported from one place to another, monitoring information such as the temperature, the moisture levels, as well as the location of the vaccine per time. While the vaccines were on the road or in the air, we were able to monitor them using the enterprise software, which we give to our customers to interact with their hardware products. And on that platform, you're able to monitor in real time the location, moisture levels, as well as temperature conditions of the products that are being transported. But beyond that, you're also able to create like alarms for excursions, meaning if a threshold is exceeded, then it could send a notification and SMS alert to respective parties, advising them on what next or what step to take to ensure that the vaccine isn't lost. Beyond that, we're also able to calculate things like rate of change, MKT on the platform to ensure that the vaccines that are being distributed are in best conditions. And if there are any issues, these individuals are advised, or individuals on the state level are advised on what next step to take to ensure that they get the best out of it, of what they receive. The moat and the software technology are relevant to a lot of other sectors which we've seen, but particularly for healthcare and agriculture. The products today are not just used for vaccine distribution, but there are applications in other distributions, such as sample that's being collected from the last mile being transported to the laboratories, organ transfer, and even in agriculture, we've seen applications such as warehouse storage monitoring, the day-old chicks temperature monitoring as well, because they're also all these products are very sensitive to temperature, humidity, as well as you want to know where their locations in case of theft or things like that. I think the Nigerian government demonstrated high level of quality assurance by making use of a real-time monitoring system. They could have made use of a data logger, which would probably be like an after-the-fact type of technology where, when the products land, then you can read the temperature, but by that time, things may have gone wrong. But with the real-time monitoring system, they were able to see, products where they were at every point in time. They were also able to see what the storage conditions were. And with this, they were able to advise each state on what next step to take, and they demonstrated high levels of professionalism, both on the federal and both on the state level, to ensure that the products that were being delivered were in top-notch quality at the end of the day. I think I would advise that as many people as possible take the vaccines, because once you have one person unvaccinated, then you have a breeding ground for another variant, which may be worse than the Delta variant. So the faster we're able to, immunize more people, I think the faster we're able to kind of draw a curtain on this whole horrible pandemic that's ongoing.
Hello and welcome to today's episode of our webinar. I'd like to thank everybody for joining. My name is Abiola Oshuni. I work as the Vice President for Growth and Partnership at Gricd, and we have wonderful panelists joining us from different parts of Nigeria today, and we'll be speaking about something that we're really passionate about at Gricd. But do me well to let your colleagues, let your friends know that the webinar started, and we're going to be having a wonderful time. Just as a background, one of the things we've noticed is there's been quite an amount of rhetorics around achieving universal healthcare coverage on the continent. One of the biggest things, if you recall, we had the MDG goals, and Nigeria, like many African countries and other low and middle income countries, had significant challenges achieving some of these goals. Then we signed up for the SDGs, and the SDGs 3 stands out significantly because of healthcare. There is a very popular paradigm that says health is wealth. Now, so if health fundamentally is a measure of the wealth of a nation, it then means that Africa, as wealthy as we may not necessarily be doing so well. So today we'll be looking at how do we, accelerate that aspect of quality of healthcare delivery. We have panelists here that will speak to a lot of data and information around that, and we'll be, doing a proper deep dive. Today we have, with us, Dr. Ifeanyi Nsofor. We have, I'd just like to call it very, very simply. I know she wears many hats, so it's very difficult to know which one to stick with. Mrs. Abimbola Adebakin. We also have Lukman Aruwo Ramimo. Please don't mind me murdering your surname. Then we also have Dr. Maurice Atoki as well. So we'll be having a wonderful time speaking to some of this. So with our panelists on this. One of the key objectives for us is to kind of drill down to one of the aspects around universal healthcare coverage, which is around quality diagnostics, access to quality diagnostics. And that is quite important because we're trying to look at a sequential process of saying, if I get into the healthcare system, how do they even know what is wrong with me before I start getting treated and my managed care? But we'll be speaking, quite holistically around a lot of aspects. But one aspect we would really deep dive in is around quality diagnostics for services, availability of quality diagnostic services. So I will just do a little bit to do an introduction of our panelists, and we will read out a bit of the profiles of our panelists. But for those that may not know our panelists, you can literally go. We would post a little bit of profiles of our panelists right now to be able for you to know, why we have them here and their wealth of experience. So, Sheyi, please go ahead and share that post for us. Okay. So we'll get right to the post in a bit, just as I was speaking about, one of the focuses for us is moving from rhetorics to real conversations. And I will just let me know, just signal for me, Sheyi, when you're ready, so that I can, I will just be able to provide that guidance on. We're having a bit of technical difficulty making the post, but I will probably do it manually if technology gives us a bit of gap. We're working all remotely. So I will start with Dr. Ifeanyi Nsofor. Dr. Ifeanyi Nsofor is a senior Neil Voice Fellow at the Aspen Institute. is a global thought leader who has authored and co-authored more than 100 opinion pieces, with 4 of them specifically focused, 45 of them focusing specifically on COVID-19. He has, been interviewed by top news outlets such as the BBC, Al Jazeera, Forbes. He is a leading voice in global health equity, health security, universal health coverage, and health research. For more than 22 years since graduating as a medical doctor, Dr. Ifeanyi Sofo has worked with government, international not-for-profit organizations, indigenous not-for-profit organizations, as well as the private sector. Dr. Ifeanyi has been involved in launching 2 successful health startups. And, I've had the privilege of seeing him work on one of those startups, in one of my previous lives or work endeavors. And presently, like I said, he's a senior New Voices Fellow at the Aspen Institute and Senior Atlantic Fellow for Health Equity at the George Washington University. Dr. Ifeanyi Sofo was highlighted as one of the top 100 healthcare global professionals on COVID, and also top 100 most influential Africans for 2022 by News Africa. Dr. Ifeanyi is also a 2-time TEDx speaker. So, you're get to receiving so much insight on that side. We also have Mrs. Abimbola Adebakin. Ms. Abimbola Adebakin, incidentally, wears multiple hats, but I'll just, read a short profile. She works presently as the CEO of Advantage Health Africa. Mrs. Abimbola Adebakin is a certified performance technologist, a pharmacist, management consultant, and tech innovator who is keen to driving performance improvement in the African healthcare system. She is the founder and CEO, like I said, of Advantage Health Africa, powering My Pharmacy, which is a franchise pharmacy chain plus pharmacy resource center. She also, under that umbrella, she has the My Medicines, which is a last mile tech-enabled access that provide tech-enabled access to medications. There is My Labs as well, which is basically promoting molecular diagnostic services. As well, she works around pharmaceutical sales and marketing distribution ventures, which is Advantage Pharma. So, this is going to be quite interesting as well. On the panel as well, we have he says he's not a doctor, but I think we have so many doctors and on the panel, but we have Lukman Aruwu Romimo. Mr. Lukman Aruwu Romimo is the MD of Inkaba Biotech West Africa. Mr. Lukman is an experienced managing director with a demonstrated history of working in the biotechnology industry, skilled in DNA sequencing, biotechnology, cell culture, life sciences, and oligonucleotides synthesis, strong business development professional that graduated from the Stanford University of Graduate Business School. He has, this is a very short profile for most of our panelists. For between all of them, I'm already seeing over plus 200 years experience working around the healthcare space. We also have Dr. Maurice Atoki. Dr. Maurice Atoki is an experienced chief executive officer with demonstrated history of working in the health development and education space. The UNSDG 3 focused on promoting health and well-being, and the UNSDG 4 focused on promoting quality education. She is skilled around collaboration and sustainability, so creating collaborative and sustainability solutions. She's skilled around building organizational strategy as well as organizational leadership. She is a results oriented private sector engagement expert with strong business development and communication skills, with a certificate focus on strategy, innovating for sustainability from the Harvard Business School. She presently works as the CEO of ABC Health. So what we've done on this panel is we have a mix of professionals across the healthcare space. So we have international development, we have people that have worked around private sector, biotech, and entrepreneurship, the business development side of health. And I would want to really dive in straight, and I would, want to focus on specific quick questions, while we're on it. We already said that one of the biggest problems we have in Africa is not necessarily the policy perspective. The policies exist, but the aspect of us taking action is where the key part is. So I would want to, start with my introductory questions of, why is it that you're passionate from your profiles? Why is it that you're passionate about healthcare, and why is, healthcare, delivering quality healthcare in Africa very important at this time and in this decade of action, as the case may be? So I'll start with Mr. Bimbola Adebaki. We would like to hear, why are you really passionate about, healthcare, and why is, quality healthcare important for Africa at this time?
Hi, Biola, thank you so much. Hi, everyone. Hi, Dr. Fine. We were together a few weeks ago. Can you hear me?
Yeah, I can hear you.
Yes, I can. Yes, I can.
Okay, great. Thank you. The question is germane because you wonder why we're not just, somewhere else doing something else. I guess, your passion finds you. As I saw that, the founder and CEO of Amazon said in something that's going around on social media that your passion actually finds you. I am one that finds solutions to things, even normally just around the house. I don't necessarily take, no, it can't be done on surface level. I always want to ask how else, what else can be done? Who else can do this thing? And, when else? If you can't approach it now, is there another time? I think also from my background, I worked in Accenture at the time when we were emerging the strategies for basic banking. So I worked on aggregation and things that had to do with industry level change. And I saw how it played out, that today we're now benefiting from the likes of InterSwitch and the likes of ATMs being distributed around the whole country, which was, an elitist involvement before, but has become commonplace. And I read something. I read that what is for the elite today in 10 years would be for the middleman or the middle income person, and in 20 years would be for the poor. So if accessing care right now is just for the rich, what can we do to accelerate its access to the middle income and ultimately to the bottom of the pyramid? I think that's what keeps me awake. What do you, get commonplace when you go to the dentist and you take your son to the dentist? And how many children can afford to have this care? Where can we bring it down? How can we dismantle models that have served us for decades but are no longer the ones that are relevant? What's happening around in accessing food or accessing electronics or accessing dresses that we can borrow as a model and bring into healthcare? So I borrow models and I think bottom of the pyramid, and I think that's probably what is driving me right now. At Advantage Health Africa, we're trying to find access, affordability, and quality all together in anything that we do. So it's whether it's bringing medicines to you in Shagamu, making sure that your son doesn't have to travel from Akure all the way to Lagos on a monthly basis to get you medicines. We'll get it to you within a day or within 12 hours. That for me is access. And you don't have to live in Lagos to access care.
Thank you so much, Mr. Adebaki. Dr. Ifeanyi, why are you passionate about healthcare?
All right, thanks, Abiola, and thanks, Abimbola. I don't know who is following who now, but two of we seem to our paths seems to be crossing. So let me start by saying that, rather quoting Dr. Tedros, can health be anything but of quality? So, I want us to bear that in mind. It's not like you have quality healthcare, you now have, sub-quality healthcare that we can manage. So ideally, we should deliver quality healthcare. Healthcare should be of quality. So for me, what motivates me? The title of my first TEDx talk is "Without Health, We Have Nothing," and I really believe that. And I think COVID-19 has shown us that without health, we have nothing. A pandemic has grounded the global economy, because the world was not prepared. But I also have a personal story to that. So I have two daughters. My first daughter is 12 years old. My second one is 9. It's going to be 12 soon. My first daughter was born with 4 different congenital heart defects. And the most serious one was transposition of the great arteries. So which means that, 2 major arteries arose, from the opposite side. So she needed an open heart surgery in India. And for us to be able to afford that, my wife and I had to take loans from our employers then. Then I was working with Pathfinder International. My wife was working with the International Committee of the Red Cross. That's how we're able to get loans to take our daughter, who was about 10 weeks old at that point, to India for a surgery that happened when she was 13 weeks old. So for me, that was the game changer, because it was a reaffirmation of the fact that we are one illness away from, poverty. Because when you think about it, that particular experience actually pushed us into poverty, because it took us like 2 years to repay back the loans that we got from our employers. And that's why for me, I have, how it is now when you say you're going to die on this hill of universal healthcare, because I don't care who you are, just one illness that you have would wipe off, virtually everything that you have put together over the years. So that's really what drives me, and especially as it affects low-income groups and how we can, really, deliver the healthcare that our people deserve.
Fantastic. Thank you so much, Dr. Ifeanyi. I'm going to move on to Dr. Morris. You work at ABC Health, and there's a lot of. I recently saw the news of the MOU signed with one of the UN agencies. And it seems like a few people wake up and sleep about healthcare in Africa. It's quite interesting. Also, what drives you, to say I need to wake up every day to do something more, to contribute more to Africa's healthcare system, in terms of delivering quality services and quality relationships around this?
Thank you, Abiola, and good afternoon, everyone. I think for me, it's just a combination of a lot of things. And truly, I must tell you, like many other key stakeholders that are not quite recognized in the health space, I did not start by having passion for health. I found myself in health, discovered the enormity of the gaps and what could be done, looking us in the eye, and the fact that what was being done in terms of scale was very minute and almost invisible or infinitesimal to the scale of the problems and the frailty of health that we had in Africa. And as I learned in the space, I began to think about what I could do, what I could plug my own capacity into to support the sector, and how we could just really be better as a healthcare sector in Africa. But I mean, what I just want to put out there, and maybe we will get into that a bit of depth in that conversation sometime soon, is the necessity to, first of all, categorize health in Africa as not the norm, the normal, level of healthcare that we see in other parts of the world. So in other words, we are in a situation where, and this is me, some of the things that I've learned and the reality that has really come to me. The fact that a lot of governments in Africa have consistently failed the health system. And as a result, the gap is really huge, Unlike in other parts of, the world, in some other continents, in Europe, in America, you will find a government that is doing the bits they can do, but as well inviting the private sector. And when I say the private sector, I mean the private multi-sector, not the private health sector alone.
Private health sector, yeah.
The whole sector. And what I find the worst in Africa is the lack of recognition that healthcare in Africa is not a private health sector or a public health sector business alone any longer. It's a multi-sector issue. And the earlier we understand that and begin to involve every other sector who are beneficiaries or victims of the health system, that is being addressed by a certain category of persons or people, the better it will be for Africa. Otherwise, we will leave health, in the hands of medical practitioners alone, not as a business oriented sector, not as a capitalist sector, and we're leaving it in the hands of health practitioners who are reliant on a failed government to do the needful, to put the right infrastructure in place. And that is not adding up. I was at a session with Professor Abayomi, the Commissioner for Health for Lagos State, last week in Wiston. And I could hear the fear of industrializing health sector in Nigeria due to politics. I mean, it's fair. But again, it's just really important for us to recognize that the fear of politics or politicians is not enough for us to particularly state that health in Africa cannot be left alone in the hands of both government and the health sector. Capitalists and investors need to come into health very urgently. The way it's done, and they can go through PPP, so government can be, by the side involved in it. But we just need to plug in other mechanisms, other models that will work for. I mean, I heard my co-panelists who spoke about the base of the pyramid, the average citizen of Nigeria, and so on. That needs to work for the bottom of the pyramid, for the average, and for the elites. The mechanisms and the model that Africa requires and that Nigeria requires, I don't think it exists in other countries. I don't think it exists in other continents. So our attempts to model after them is also a failed attempt. It's also not the process. We need to look inwardly. We need to assess what the situation is. We need to customize our solutions and we need to apply them. I'll stop there.
Thank you, Dr. Morris. I was going to cut you, but you really have gone into the depth of some of the conversation. You started taking some of the meat of the conversation. I'll just quickly go to Mr. Lukman. Why are you passionate about healthcare? And I would like you to make it punchy and apt if you can, because we have so much to go through as time permits us.
Yeah, absolutely, Abiola. Good evening, and good evening to the other panelists. Unlike some of the panelists, my foray into healthcare, thinking about it was accidental and also inevitable. So my background is in molecular biology / biotechnology. And about 10 years ago, I came to Nigeria just to explore the opportunities within the biotech space. How big is the market, what's going on, how are researchers managing to do research in Nigeria. And then I realized that the level of coordination was pretty much non-existent. And I'm an adventurer, by the way. I love traveling and just exploring new territories. So what I did was I sort of took it a step further and explored other West African and Central African countries. So I traveled to pretty much every country in West Africa. And what I realized was this is not a Nigerian problem. This is indeed an African problem, because the issues in Nigeria are very identical to what you'd find in Mali, Ghana, and the rest of the continent. Although I was operating within the genomics/biotechnology space, I just want to put it out there that the area in which I operate is the less spoken about and perhaps less glamorous bit within the healthcare value chain. So what I do is we supply the reagents, the equipment, the technical support required for laboratories, research lab, diagnostic labs to conduct their research. And it was quite unfortunate to see that there was absolutely no coordination within that space to get reagents for your equipment, your your chemistry analyzer, your molecular diagnostic. There was absolutely no coordination. Today it's a lot better, but what I realized was that there was an urgent need for a player within that space. And within the past 10 years, my company, Cover Biotech, what we've done is we now have offices in Nigeria and pretty much every sub-Saharan African country. And we grow significantly every year because our goal really is to see how much of this value chain problem we can solve. The accessibility of the reagents, should the equipment break down along the way, are there trained engineers within the country to fix these problems? We have very few engineers in country who can fix these problems. And this is sort of my focus. This is the area within which Cover Biotech is trying to solve a problem. So I share this passion for healthcare. And today, I think I would say Nkaba has become more of a healthcare company than a genomics company, but our foundation really is still in the genomics space.
Thank you so much, Mr. Lukman. For our participants on the webinar, our focus, like you rightly know, is we're speaking to our panelists, Dr. Maurice Atoki, Dr. Ifeanyi Sofor, Mrs. Abimbola Adebakin, Lukman Arowo Romimo, on leveraging innovative strategies for improving the quality of diagnostics. But our focus fundamentally is how do we move on a little more in terms of achieving universal healthcare coverage or quality of healthcare coverage in Africa. It's been, some of the take for me was some of the quotes from, Dr. Adebaki, Dr. Morris, and also I think one of it is, the quote that he said from Dr. Tedros, can health be anything other than quality? On that note, I would like to, start the other rounds of questions. Dr. Ifeanyi, one of the things, like when I started the conversation at the beginning during my opening statement, I talked about our inability to meet, that we're not able to meet the MDGs. And now we're literally staring at the next target of the SDGs. It's less than 10 years from now. Are we really positioned as a continent to even meet the SDGs at all? If we take a retrospective look at how we've structured policies and all of that, are we really positioned? Are we taking action? Are we anywhere near what we can say we are able to achieve that target?
Okay, thanks, Abiola. So I'm to be honest, personally, I'm really not bothered about these global targets because they're just semantics at the end of the day. Anytime with the work that I've done around communities, when I visit any community, the first question I want to ask is, when a woman is pregnant in this community, where does she give birth? What are the processes involved? So I'm much more interested in providing care that our people need, equitable health care that meets them at the point of their need. But since we're talking about universal health coverage, I also want to, again, remind everybody of WHO's definition of universal health coverage. One of the many definitions, that is a spectrum of care. Universal health coverage is a spectrum of care. So there is health promotion, there is prevention, there is treatment, there is palliative, there is rehabilitation. So it's a spectrum of care. So the question is, when you look at this spectrum, how well are we able to deliver the care that our people need? No matter where it is that they live, no matter where it is, no matter their income, and their access to finances, which also, takes us back to the other aspect of universal healthcare, being able to afford the care that we need. And I like what Abimbola said about, you don't have to live in Lagos to have, access to, to affordable and quality medicines. Because I think that for too long, we have looked at healthcare purely from, an altruistic point of view. People, we didn't look at healthcare as a business, bringing in deep business models that have worked elsewhere. You get what I mean? So, and just using the example of, a woman who gets pregnant today, what kind of care does she get, depending on where it is that she lives? How are we able to ensure that that woman doesn't suffer any kind of hardships as, for her to be able to access the care that she needs? And I think a lot of it, as far as Africa is concerned, is the fact that I think apart from Rwanda in Africa, that Rwanda, if you look at their Vision 2020 plan, actually identifies healthcare as a precursor of economic development. Yes. So they're a country that looked forward and said, for our people to move forward as, economically, everybody has to have access to healthcare. That's why coverage, universal health coverage, is about 96, 97% in Rwanda. Yes. You get what I mean? So as a people, we need to prioritize healthcare. As governments across Africa, what kind of priority do we give to healthcare? Because until, we prioritize healthcare, then we can start, before we start talking about whether we meet some of those targets. Some of those targets are just dreams, when we've not set, motions in place within our communities, our country, to reach, to provide the care that our people need.
Thank you very much, Dr. Ifeanyi, for speaking to the concept of the idea of models, and the idea that we've basically looked at healthcare as more as a social venture, an altruistic idea, rather than something that is actually in itself a business. Mr. Abimbola, I know you've played a lot in the management space. You run a private sector company. You run Advantage Health, and I see the multiple dimensions you played with Advantage Health. But more critically, one of the things I've seen is that the private sector focuses, yes, greatly on profit, is incentivized to deliver care. But within the African framework, do we think, the private sector is appropriately aligned fundamentally to helping the continent achieve the SDGs, SDG 3 specifically?
Yeah, so there's so many dimensions, the SDGs, health for all. Is it in communicable diseases? Is it in non-communicable diseases? Is it in addressing accidents? Is it in promotion, prevention, even rehabilitation of people and providing palliative care? Most of our focus is in curative care. I understand that because it's so emergency, it's so needed now that's our focus, short term. Private sector or public sector, I don't think it's one or the other. It's really a combination of both that will address whether we will arrive there. Standing at my point, I'm not sure we can make it. I might be pessimistic. But you see, is that really what we're aiming for? I think, first of all, we should build sustainability and systems into what we're doing in healthcare. And the private sector comes with an incentive to build that. There may be others that don't have the incentive to build it, and what they're looking out for might be different. But the private sector, we must build, when you invest in a certain thing, you want to make sure you get a lifetime return from it. When you build a new market, you want to say, okay, there are 1 million people here, but there will be 3 million next time in a few years. So I'm planning for growth. We need to do that with healthcare. So we will ultimately have health for all, but I'm not sure it's private sector or public sector. It's both of us creating systems and creating sustainability. It must be beyond whether it's private sector and whether we're for profit. What we bring to healthcare is that there is a business of healthcare that will make it happen. If we choose to, ignore it, we do it at our own detriment. There are people who will seek care. Okay, let me give a quick example. I think that everybody should have a health insurance in hand. It just makes sense. But
Makes
in
sense.
Nigeria, we have less than 5% of us with health insurance.
True.
A study was done and they sampled about 5,000 people and said, would you want health insurance? And almost 77% of something percent said yes. Do you have health insurance?
You have insurance.
14% of them said yes. So there's a gap between
There's a gap.
40% that have and 77% that
I
want.
want it. Yes.
What I think we should do is bridge that. Whether it's private sector led, public sector, a combination, we need to bridge that. What do people desire? They need a cover. They want a cover. And how do we bridge it? If it is me bringing a model from a marketing model that I've seen work in how we sell toothpaste, and I bring it in how we sell health insurance, you may say it's private sector, but the ultimate thing is to get people to have
People are
insurance.
covered.
Yeah. If it is the government saying you must have at least a basic cover, that's government.
Mandatory health insurance.
So the point is we must have health insurance. Now, when we have health insurance, you have a pool of funds. What we then do with that pool of funds is left to all of us to correct. We must build systems. We must build infrastructure. We must build incentives. We must create social media, social communication channels. We must put incentives in place for performance so that healthcare providers are incentivized to give more than just the surface. So we must also reward them well. When I look at what's happening in private sector and public sector, and you find that the doctors in private sector do not go, they don't down tools. But the doctors in public sector down tools.
Down tools.
You wonder what's going on, how they incentivize. People can borrow models from private sector and use it in public sector to incentivize them. It goes beyond pay.
True.
Sometimes you pay more in public sector. We have pharmacists who refuse to work in community pharmacies when they're for internship. They rather wait to work in a public hospital. So it goes beyond pay. It's the condition of work. It's how they're respected. So many other things. So I'm saying so many things that I haven't quite said one, but it's not a case of public sector versus private sector. It's for us to work together. I like what Dr. Morris said. We need to find our own model that works.
Exactly.
I'm tired of people thinking that, healthcare in Africa. What is healthcare in Africa really?
What really is it?
Yes, there's different things happening in different countries. Lukman said he's been across Africa and he has seen similarities, but there are also differences. Francophone from Anglophone. What are the similarities and what are the differences? Let's marry and find what works per country. In Nigeria, social health insurance is still a new thing to many people. We still have so much penetration to do. Do we have the right agents in place that will make it happen? Are they rightly incentivized? Is the NHIA right now incentivized to make sure that across the country we have 100% compliance in the next 3 years? Can the states achieve it? Or if a state reports 1 million people have insurance, it's bravo, because they moved the needle. But 1 million in a state that has 6 million, is that what we're aiming to have? I just think that there's so many considerations, but the private sector method of working towards milestones, goals, KPIs, and all should be adopted across, and maybe then we'll get work done.
Thank you, Dr. Adebaki. Mr. Adebaki, that's quite loaded. That's quite loaded. Lukman, I'll just come quickly to you because of one of the aspects of focus around the universal healthcare coverage that we're looking at, which is the diagnostic space. And you've worked for a while there, and you talked about coordination. What has quite incidentally, you just talked about you being there in the last 10 years. What has really changed in the last 10 years? Because personally, I saw something very different when the COVID hit. You would go to a diagnostic lab before, and you would probably wait for a whole day or 2 days to get your results. But all of a sudden, I started getting digital versions of results in a matter of hours. So what literally changed? You know, what changed the model within the diagnostic space where, you know, I saw that modularized version of even people could come home to take samples and you could take those samples to what changed, you know, within the last 10 years that has kind of created some value within the diagnostic space, that we've seen that departure that happened during the COVID for whatever reason and made it seem like diagnostic services could be actually of better quality than we used to know before?
Yeah, I don't know if a lot has changed within the past 10 years, but I can tell you a lot has changed in the past 2 years since COVID hit. And like you rightly said, the COVID testing labs, they were extremely efficient. At the beginning, it was a bit shaky, but they did get efficient. And for me, I think what I would say is just follow the money. The way the COVID testing space has been set up was one where you had to do the tests. You know, if you want to travel out of the country, it had to be done. You had to pay for it. So as a private diagnostic lab, I somewhat had the comfort that there was ROI on my investment. Exactly. For me to invest and invest in efficiency, invest in the manpower required to get me to the level of efficiency that would drive my bottom line and attain my desired ROI. Now, with respect to just still on the diagnostic space bit, I think within the Nigerian context, it's really important to explore the PPP model where there is a marriage between the public sector and the private sector. And I would use a case study of teaching hospitals in this case. So most teaching hospitals in Nigeria obviously have big volumes. By volumes, I mean influx of samples, right? And from what I've seen on ground in Nigeria, they are not exactly the most efficient at running diagnostic labs. Now, to be honest, it's not necessarily to a high degree the fault of the managers of the teaching hospitals. But with the private sector coming in and perhaps a collaboration between both private and public sector, with the private sector, I come in with the equipment, with the manpower, or just my efficiency, and obviously with the profit drive. And then with the public sector, your role really is to provide an enabling environment, the samples for private sector laboratories to thrive. And I've seen hospitals where this works, and I've seen where it doesn't work. Of course, we know what the challenges are where they do not work, but I really think for the diagnostic space to thrive and for efficient testing to be done in scale, it's really important for the marriage of private and public sector to happen. Private sector obviously is driven by profits, and for the public sector, your goal really is to ensure that you deliver good quality, high quality services, healthcare to your users. And I think if we can explore this private sector collaboration and public sector collaboration a bit more in Nigeria, it could really work for us. And like Mrs. Abimbola said, what works in Francophone Africa might not work in Anglophone Africa because the challenges are very different. Every country has its own peculiar realities. And I think we need to explore what these individual realities are and tailor-make the solutions for each country and perhaps each value chain of the healthcare space, be it the hospital, the primary healthcare facilities, secondary, tertiary, and then the diagnostic labs. Yeah, thank you. In a nutshell, I think the PPP model in Nigeria really needs to be explored a lot further and perhaps institutionalized in a way, and then each hospital can then think about how to design a system that works within their own realities.
Fantastic. Thank you, Mr. Lukman. I hear a lot of rethinking our business model of delivery of healthcare. I hear a lot around, kind of breaking down what you would have called the geographical walls that say, okay, Nigeria must act as a unit system, or Africa must act as a unit system towards health. But this is about focusing on your unique realities, and then gearing those unique realities towards the way you position yourself. Dr. Morris, I'll come to you now. And where I'm coming from is around the angle of these unique realities that we saw, and I like what Lukman talked about during the pandemic. Right, I saw that there was a significant amount of mobilization of resources towards the pandemic that the private sector actually led. And one of the biggest gaps we have when it comes to healthcare is there's been that systemic delay, or the systemic gap in allocating the right amount or adequate amount of resources to healthcare, for many years. And when you have a surge, maybe you have a pandemic such as COVID, there's really no system that can quickly mobilize funds on the side of government. However, we saw the private sector on the continental level and on at country levels individually mobilize so much resources that actually, if I may say, almost outweighed what government could have done in the amount of time. So there was efficiency in terms of mobilization of resources. However, there's also, I noticed there's now that skewed effect, and I use this example as a skewed effect. Quite a lot of venture capitals and a lot of investment in healthcare is literally from out of the continent. So there is now that departure of, during the COVID pandemic, we saw the private sector guys on the continent investing in healthcare. However, if you look at the amount of investments that go into healthcare from within the continent, is not as compared to what you have, as compared to what we had during the pandemic. Why is that gap there? And is there a way, that gap can be addressed to make it more interesting for players on the continent to actually begin to invest more? Because we know that if they do, there's some form of significant change that will begin to happen. Dr. Morris.
Thank you so much, Abiola. I'm particularly excited for the question that you've asked me because it seems to be my forte. And I tell you two things. I'm going to gather some thoughts from where Dr. Lukman, I think he said he's not a doctor, landed. And I'm also going to just try to add mine. First and foremost, I think we shouldn't be shy to say that it is very unlikely that Nigeria, and particularly Africa, will improve in health if health is left in the hands of the public sector alone, as it is and as required, because generally we know that government is responsible for public health. However, what I see that is most even alarming is the inability to optimize the interlinkages of what government can actually still do and what private sector can do. So therefore, it seems that what government is doing now, maybe because of funding or lack of it, is either at zero level or very insufficient. And then private sector in the capacity that it can gather are doing what they can do. I mean, private health sector. However, if we relook at it, for instance, let's even talk to the PPP model that Lukman spoke to. So Nigeria should think about a PPP model. Yes, Nigeria is thinking about a PPP model. But it also seems like government is still stuck in that area of responsibility that's generally and by model, which cuts across other governments all over the world, they are responsible to, so the public health space. But they have consistently failed. And I think if you failed somewhere, for decades, I think it's high time you have to rethink the model. I do think that the PPP model just like Lukman said, should really be considered. And I tell you a bit about what is happening in Rwanda. So I've had sessions with the Minister for Health. And, just as we know, the PPP model is very effective for them. What is a deliberate attempt by the government to use that model to build the capacity of private sector to be able to fit into that model that they require in partnership. And that's what I think is lacking. The ability of government to rethink the current model and begin to think about building capacity for the likely strategic partners that will come into the PPP model that is so desired. And where are this category of persons? Usually health entrepreneurs. And in other countries, in other advanced countries, you see, a lot of the health capitalists have been built because they were supported either by strategic partnership or funding. The government needs to be seen to consider the health space as an economic development space that they want to invest in, and not just as a social space. The fact that they're still considering, oh, let's just help them, let's just make them, no. Health is even, and Abiola, you see, you are still saying health is wealth. I was with Obasanjo 2 years ago. He said, health is more than wealth. And we're at that stage now to recognize that, see, without the health of the citizens, we are nothing and we're nowhere. We're not going to grow. The system is getting frailer and frailer. The fundamental problem of the fact that those private health sector that our health has been left in the hands of do not have the capacity to seek the right kind of funding to scale, to be able to partner in the PPP models that the government requires, are gaps. And until all of these are, demystified and broken into parts, then we'll still be dancing around circles. I think it needs, and that's why I talked about multi-key stakeholdership. There's a lot of business analysis. There's a lot of economic growth analysis. Health economists needs to go into the scenario more to assess, more business models and more economic models to be able to advance health in Africa and health in Nigeria. Leaving it in the hands of our darling doctors alone, who are trained, to take care of us, expecting them to apply the business model of assessing funding and growing health might not work. And I'm just being modest. I'll leave it there for now.
Thank you so much, Dr. Morris. I want to come back on that very high note to Dr. Ifeanyi and Ms. Adebaki. We said this session is going to be looking at very practical approaches. And, Lukman as well, you've talked about the PPP model. Dr. Ifeanyi, what models have we used? So for instance, I know the contact tracing model that we've mastered in Africa was what literally was used in the West to be able to manage contact tracing for COVID. I saw a lot of continental colleagues that got international jobs because they were masters at understanding and designing micro plans that we built on the continent for our routine immunization coverage and contact tracing. So what models can we, from your experience, from your work in the space, what models in addition to the PPP can we use? And Dr. Adebaki, please Ms. Adebaki, please do feel free to jump in because of your work with Advantage Health. What models can we begin to use now to get Africa to a more comfortable space in terms of moving us towards that our target and getting quality healthcare delivered to our citizens?
Okay, thank you, Abiola. Well, I don't think there's any particular model. I think it's left to to the organization to determine how they can get healthcare to people. But I want to speak specifically about health insurance that Abimbola has spoken about, because it's something that I'm really very passionate about, and I've done some work in and also written about. So let's look at there's something that the WHO calls national health accounts. So periodically, after every 5 years, a national health account is done in Nigeria to say what is the total health expenditure and who pays for healthcare?
Mm.
So the last one that was done in 2018. The total health expenditure as our 2018 estimate in Nigeria was $10 billion every year.
Mm.
Now, $7.7 billion out of that amount is out of pocket. People pay in order when they are sick to access healthcare.
So we don't have a problem of people wanting to pay for healthcare.
Absolutely, no, we don't. People pay. And $1.1 billion is the international donor support. So all these things you see people killing themselves over international donor money is 1.1 billion, which tells you that Nigerians spend 7 times what international donors give us. So if you ask me, we shouldn't be bothered about international donors here. We should focus on Nigerians who have that, disposable income to pay for healthcare, which sometimes are substandard healthcare. Now, if you look at that $7.7 billion, about $2.2 billion out of that $7.7 billion is spent in chemists and pharmacists.
Wow.
Do you understand? And I've written articles, for DevX, for instance, where I said it is time for us to rechannel that huge out-of-pocket expenditure towards health insurance.
Yes, absolutely.
So if you're talking about a model, the model I want to see is how do we convince Nigerians? See, we don't want you to spend extra money. We're just saying that $7.7 billion that we already spent out of pocket,
channel into insurance.
A fraction, not even everything, but a fraction of it for health insurance. My health insurance provider is AXA Mansard. Yesterday I got an email from them. They now have a health insurance plan, 12,000 naira for 6 months. And you get some package of healthcare. You have Reliance HMO that has kind of they have broken down the process that you can pay monthly, about 3,500 naira monthly for a package of healthcare. So, and that's why for me, talking about a model is for a particular startup or an organization that wants to intervene, look at this huge amount, $7.7 billion available. How do we get Nigerians to get health insurance? 2 things that governments have done, even before the president signed the NHI Act, about 2 weeks ago.
Yeah.
Virtually every state in Nigeria now has a mandatory state health insurance scheme.
State insurance scheme, yes.
So if you're working within a state, how can you tap into that to get Nigerians resident there? Because this is mandatory. In fact, when I heard that President Buhari has signed the NHI Act, I was like, well, this is late coming really, because as far as I'm concerned, that act is just for federal workers and federal workers who are residents in Abuja and federal workers across the state. So how do we tap into this opportunity that exists? That for me is where the innovation comes in. But of course, people like Abimbola have, really brought out other innovative ways of, getting drugs across to our people. And Abimbola, I need to hand this mantle over to you. I'm sure you have a lot to say.
Thank you. We must crack health insurance. I get tired when people say Africans are poor and we spend so much on data and we say, oh, we can't spend on health. It's because data has been made like air. If you don't have data in a day, you will borrow. And sometimes you borrow 4 times a day, 100 now. By the time end of the day, you borrow 400 now. Just to stay in touch and check your betting, results, and also, social media to yab the latest person. So we must make health attractive and value-driven, so that people will think, you know what? Let me set aside 2,000 naira for health insurance. Let me set aside maybe 200 naira daily for health insurance, or 100 naira daily. It's going anyway. So I can borrow and make sure I'm alerted and gamify it in such a way that it's attractive, we make it a league or whatever, we need to make it fun.
Yeah.
I also think that, so PPP is one model that we must milk and use different. We must also bring project finance into healthcare. With project finance, unitize, and you focus on an area, you show the indices, the return on investment, and then bring the money, put it in there, and give it back to the people that brought the money, and make it such that it's worth their while, so that we don't tell stories about health being, it's for charity or it's for altruistic. They don't want to hear that. They want to hear that invest 100 million into this facility or into this process. We will give you the return because the people will pay when they come. And people will pay. People already pay. You go to the hospital and say it's free. It's not free. They pay. You say, oh, it's free, but they go and buy these kits. They go and buy that. They bring it, go and buy needle, go and buy gloves and all that. Why don't you make it clear for them to pay for it here, and a portion of it goes to refund for the investment that came up. The other thing that I think we must do is that we're a circuitized economy in many levels, and we think that we shouldn't bring that to healthcare. We must. We must. So far, we're using just this one. Oh, you go to a hospital, go to a clinic, and see the doctor, and do every other thing in there. I'm saying that that's the only one. So what if we dismantle it, disaggregate it, and then you pay for it in bits and pieces? People tell you, oh, that means the patient is going up and down. The patient is going up and down already in many ways. So why don't we bring it to the patient? I will bring drugs to the patient. You bring the diagnostic, take his swab, go and then give him results. You bring the nurse, So, but we unitize it. We dismantle the overheads that are too many, they're creating fats. People can't pay for fat. If I want to then sit in a place and get that kind of care, that everything is all in one, then I know it's premium. Let me pay for premium. But a situation where someone is paying 40,000 for drugs and comes out of the clinic and realizes the drug is just 6,000, it is harmful, and it has caused people not to trust us to come to the hospital. You find people. I have a friend who rescued a girl that had just been in an Okada accident. And he carried her, everything, took her into the hospital, from there referred to another place. Her people came quickly to remove her and took her to the village. She's okay now, thank God. But why did they quickly come? Because they don't trust the bill that will come out from the hospital. That's the only model we're using. It's not sustainable. People don't trust accessing care through our traditional means. Therefore, they won't come to bring that money. They won't bring it here. They keep paying it elsewhere. And so accessing care comes very late. I think one more thing I would like to say, I think Abiola dropped out, but can you hear me, Lukman, if I?
Yeah, we can hear you.
Okay.
Yeah, we can hear you.
What I would like to say is about task shifting. If we embrace task shifting as we should, many of the processes that people need to get care will be cascaded to those who are healthcare workers and peri-healthcare workers, and they would offer it. Instead of relying on a doctor or nurses for some child deliveries, train the traditional birth attendant, train many people, and move them out there so that they can do 90% of the simple things, and the complex ones can be detected early, and then you escalate to where it should be. All right, now we're taking primary care and hoarding it and holding on when it should have been disaggregated and dismantled, and we should find the areas that are for others to take care of. The doctor, I think, is overprotective, and I really understand. I really, really understand. You don't want to dilute care. The pharmacist is also overprotective, and I quite understand. And I tell pharmacists, we should have moved on. You are protecting a sector that many of the things we're doing are being done by pharmacy technicians abroad. And here you're holding on to it. What you are doing is you are limiting your ability to move up the scale and do more value-added things that you'll be paid better for. But when you are struggling for the job that could have been outsourced or given to a pharmacy technician, your pay cannot increase. Your value will be questioned. And in the scheme of things, everybody's trying to keep value cost low. You may be edged out. So instead, move up. Become specialists, become more relevant in the care of the patient, and then administrative and processes, things that are really transactional and administrative, can go further down. This is a model we use in strategy and organizational design. We can take it and put it into healthcare. So task shifting is not new. It's not rocket science. We use it. We automate several things in organizational design. You come into a product and you automate leave application, automate recruitment, automate so many, so that the HR specialist can focus on more strategy inclined work. But here in healthcare, we want to do everything manual labor. It's keeping us busy, but less value adding. That's why pay cannot increase. The doctor is poorly paid right now. So I think that we must just borrow models that are used in other sectors. What is the financial services sector using now? The fintech is a key element of financial services. So when we say health tech, we're not saying health tech will replace. It's not here to replace. It's to augment and catalyze efficiency and effectiveness. I'm bringing health tech into pharmaceutical distribution to the last mile. So Gricd is, bringing, up the value chain. Somebody else is bringing diagnostics. We can go to people's homes. We should see how to scale these things rather than say, they're not relevant. They're not. We will scale them so that we free up time, we free up space for more people to walk into the hospital and get all the care that they need. Ambulance services still has to be disrupted. Referral services have to be disrupted. So many things have to be disrupted, and then technology brought in. So task shifting, PPP, project finance, disruptions that come with technology, all of these things must come in. What are we doing in clean tech that we can use in healthcare? What are we doing in food tech that we can use, agri-tech that we can use? For example, with agri that everybody can contribute and crowdsource funding, and then we all own a cassava farm, and then at the end of the day, we get return. Some have worked, some have not worked. Can we do that for hospitals? Can we crowdsource, fund the hospital, and get it up and make sure it is delivering, and then we pay people back their money? It may not be at 200%, but it may be at 80%. But for us to not test models and use models, I think that we're doing ourselves a disservice. And there's some people that just are benefiting from the system being as it is, but it cannot last long. We must break those molds. I know Abiola has gone off, but because it's still being recorded, maybe Dr. Morris, I saw your hand up.
Yeah.
Maybe you.
Oh yeah, thank you so much, Dr. Adebakin. And I must really commend your robustness. You've actually really spoken on a lot of areas as far as this conversation is concerned. And I'm going to, my own remarks will be based on maybe the last component of your remarks. And it is the fact that we also must recognize that one of the driving forces to grow a sector is competition. This disruption that you talk about, one of the things that can make an average health business or healthcare, the private healthcare, think outside the box is if he sees like 10 others around him and all of his customers are going to the others. It will be compelled to seek financing. It will be compelled to add technology to enhance its effectiveness, and so on and so forth. Just a lot of examples. But I do think that really seriously thinking about capitalizing the health sector is fundamental for Africa's health. So, I mean, being a capitalist sector brings a lot of things, but majorly it brings the reason why private sector is results oriented, and the reason why they want to protect their brand, and is because they want to stay in the market. I mean, look at the financial services sector. They are in the market and they are doing better every day because they are thriving. They are thriving because they can compete and they can be better, so they can better deliver value. The health sector is not yet like that. And without taking away the ethics of health, because I'm being mindful. I mean, I don't have a health background, I have a legal background. And I got into health and I got more, exposed to it in a positive way. And I started realizing that just like we have in other sectors, the health sector has a lot of knowledge-based practitioners for health. The other sector, which seems to have been supporting the health sector, especially in Africa and in other parts of the world, seem to be the government, not supporting. I mean, they're the one, they're supposed to be the owners, actually. Yes, they oversee. But unfortunately in Africa, they failed. They failed, but we're not really talking about it. We're not really talking to it. And so it's just really important that beyond health practitioners alone, there has to be a wider approach to address fundamentally how healthcare needs to be improved in quality, in delivery, in accessibility to the populace. And lastly, I just want to say something. I want to talk to insurance. And I hear a lot of, and yeah, I mean, for the health sector, it's good news. A bill was passed into law recently by the president. We've been expecting it, so we're happy. But do we also remember that the people on this platform were just about 2% of the population? And we're the ones that will likely get access to this insurance. The informal sector are not going to go after this insurance. So let's just also, take that. Even though, arguably you can say that we affect significantly a large part of the economy, but so also the informal sector. So insurance by itself is not sufficient to adequately address the enormity of the gap that we're talking about as far as healthcare is concerned, both in Africa and as well as Nigeria. Over.
Thank you so much. Thank you so much, Dr. Morris. That was quite interesting. I want to move to Lukman a bit, and I want us to delve a little deeper. And we have some questions coming up already, and I will share those questions with you. But I wanted to kind of delve a little into the quality delivery for diagnostic services. I did about it a bit. Dr. Morris talked about breaking that model well, and then looking at, because I would think, and then looking at how to deliver services, even to the very informal sector. As of today, I don't know how much, not sure how much, depending on the kind of health insurance you have. For instance, take Q. I'm not sure that there are certain kind of tests you'll be able to do. And I'm not even sure that the technology exists across the country for you to do certain kind of advanced, tests, as the case may be. And if they do exist, they come at a, somewhat of a premium. And of course, just like what we saw happen in the telecom space and what we see in the banking space.
Ella is gone again.
I think you can go ahead. He almost completed what he was doing.
So,
okay.
So how do we access to innovative quality care, innovative solutions? You talked about, DNA sequencing from your experience. And I know that, precision and personalized care is what the West is talking about right now. How do we get access to such care right now on the continent, leveraging whatever models that we need to leverage in this case? Lukman.
Yeah, thank you, Biola. So, the advanced tech is important, precision medicine, DNA sequencing, and all of that. However, I think if we don't solve the basic, malaria tests, I don't know why we're even having conversations about DNA sequencing. And what I've observed in the past few years has been the key role pharmacists have been playing in the healthcare value chain. And obviously, there are a lot more pharmacies around the country or in more rural settings, chemists, I think that's what they're called, across Nigeria. Can we explore how to somewhat embed diagnostic services within these pharmacies? Because I think an average Nigerian, whenever they fall sick, in most cases, I would say minor illnesses, I don't think they go to the hospital. I don't think their first stop is the hospital. I think, and please correct me if I'm wrong, Mrs. Abimbola, my suspicion is their first stop is pharmacies. Now, is there a way we can innovate around this customer behavior in Nigeria? If the customer or the patient, in this case, first stop is the pharmacy, can we explore an embed where these pharmacies, in addition to providing the first line treatment and drugs, are able to conduct basic tests? And I suspect that this probably has to be done by existing laboratories, right, where they can create some kind of hub and a spoke model where they collect samples with their spokes and then perhaps working with pharmacies and then shipping to the hubs where they're able to do more advanced tests. I know I'm not the moderator here, but I'd really like to have the thoughts of Mr.
Yeah, you're
Gazipo and
correct.
perhaps the other
Yeah, you're
panelists on this.
absolutely correct, man. And the hub and spoke model really worked for COVID testing. When you went to a pharmacy, you could do I went to France, I could do either a PCV or the simple test, rapid test. And I know that the timing was based on when the lab would come and bring, and all that. But you see, we have gatekeepers, entrenched gatekeepers who are speaking in one direction that seems to be against what those of us who want to cause that change are saying. I'll give you an example. So diagnostics right now in Kenya, there's a lot of, they put digital diagnostic tools across clinics and pharmacies. And with all of that, you have more access to diagnostics. And you can, immediately get, an informed decision. And with telemedicine, you can get a medical doctor to assess everything and be able to consult with you by video, and you've got care. It's as though makes so much sense, and then some gatekeepers tell you you're not permitted as a pharmacist to have diagnostics done in your pharmacy. He said, but the people, they know me as the person they trust in the community. They come here for toothpaste. They come here for condoms. When they're ill, they come here and they trust my pricing. They trust my advice. They know when I say, oh, you don't need medicine, go and sleep or change your mattress, your back will be fine and all that. So they've trusted the pharmacist, but we are underutilizing the pharmacy. Look across how we categorize primary health care in Nigeria. The pharmacist is excluded. And you say, how? More than 50% of care is first accessed at the pharmacy. So you should include the pharmacists in primary health care strategies and get it to utilize us. But gatekeepers are thought otherwise. Same gatekeepers who will have showed statistics, figures, that we tested, we did vision screening for 600 people through pharmacies, and 12% of them needed more care. We were able to refer them to optometrists, and they said, no, you have nothing to do there. And we say, but these kits that we're using have been customized and are being used across Africa, and we can bring it here. It's not encroaching on your work. In fact, it brings you a better pipeline of human beings to come into your clinics. People who will never come into your clinic, they will not come because they don't even know they have eyesight issues. But just say, let's screen you the same way we said, I come to blood pressure. They say, no. Put a ban, locked up pharmacies that have been building reputation for 20 years. You lock them up and you say they're carrying out their charlatans. We're not yet ready for what we need to do. If you as a gatekeeper cannot work with data that I give you, all you are resting on is feelings and emotions, then we cannot talk intelligently. I had a pharmacy locked down many years ago, 2007, because we were checking blood pressure, and they sat in there, they came, ghost evaluators, and we checked the blood pressure of a man. The lady that checked it saw that the man had 170 over 110, and advised him, Baba, you have to go to the clinic. After he left, they shut down the pharmacy, saying there was no one qualified to do it there. And I said, come on. Even blood pressure monitors are at airports. You can check it while you're waiting to catch your flight. Why would you then stand as a gatekeeper and see the obvious and say it's not allowed? You see, our mentality of it's not allowed has kept us back. But entrepreneurs like us come and say, okay, there are still some loopholes where we can explore. When I started online pharmacy 5 years ago, I was told it is not allowed, it is not allowed. But by sheer force of my character, I said, but where does it say that it is not, you may say it's not allowed, but where does it say it is disallowed? And nobody could bring that up to me. That's okay, since it is not written disallowed, I'll push ahead. This year, we finally have guidelines, rules around online pharmacy, and I was called on the roadshow to help to sensitize people around it. You see, we must push the envelope. That's where we must go to. Healthcare needs change. We cannot rest on models that worked in the 70s and the 80s. In fact, longer, and think that we will do things here. I really thought COVID would cause a change. I really thought seeing how we can unitize and sachetize healthcare, we now will embrace it. We'll all see, but it appears after the, intense lockdown period, we've gone back to the trenches and gone back to the same mindset we had before.
Thank you so much, Mr. Debaki, for that insightful, contribution. One of the things, one of the questions we had, two questions, in fact, spoke to the conversations around data and public health data fundamentally, and I would like us to jump on this. So one of the questions, and I'll combine the two questions. One of the questions talked about the granularity of the COVID-19 infection data available in public fair, the validity of that data, particularly because it was only public sector that was literally managing a significant amount of the cases, or was allowed, if you let me say that, to manage significant amount of the cases. So I want us to take it from two angles. From the testing side, Lukman, Mr. Lukman, what was your experience in terms of what you were seeing in terms of people coming to actually wanting to test, and the testing frequency that people were actually having? And also, Dr. Ifeanyi, I'd like you to speak to the idea of the validity of that process, because one of the biggest things that we saw was, and quite enough people had a lot of hesitancy to the vaccines because they couldn't trust the data. How in this case can we say that we're literally using data to inform the process? Dr. Morris as well. So please feel free to jump on this as well. Look.
Bella, unfortunately, I'm not an authority on COVID-19 test data because my company provided support to labs that did the test, and we were not interfacing directly with the patients. However, what I can tell you is indeed there is a bit of disparity between, what I can track on my end is how much reagents are we testing, are we selling to the labs? And then when I just suppose that against the numbers that is being released, I can say that there is some disparity because we have an idea how much, because we were working with, I would say, a good number of the labs in Nigeria, and there's definitely a weak correlation between what the labs were buying versus the data that was being put out. But as I said, I'm not an authority on the actual test data, so I won't unfortunately be able to answer the question as you'd like me to. Biola, your mic is muted.
Thank you.
You want me
Dr. Ifeanyi, I know you wrote a lot of articles around COVID-19 during that process. And, and one of the biggest questions here was, the accuracy of that data, especially because just like Mr. Debakin talked about, quite a number of people literally had more access to pharmacies and people that you could call that had, community contact with them. How can we really say that data that we had on the continent or in Nigeria was a true reflection of the circumstance that we have? And also remembering that we are still very manual in our data entry process. How does that really create, validity and trust on the side of the people?
Okay, so I think one thing we need to run away from is to always think that anything coming out of the African continent is bad, because there's been a global study on COVID-19 data. Every country on every continent underreported. Obviously, some underreported than others. So the question of underreporting, to be honest, if you looked at some of the challenges that countries like the US had at the beginning, you'd be shocked that it was coming out of the US. So everywhere underreported. Do you understand? But the way I try to look at this is that, so how many cases are reported? are we reporting? How many people have died? Even if just one person dies, that's a big deal. Have you guys lost me? I feel as if I'm talking to...
No, we're here. We can hear you. We can hear you. We can hear you. Dr. Ifeanyi.
All right. So even if just one death, that is one death too many. You get what I mean? But we know that if we come back to Nigeria, for instance, we know that as far as COVID-19 testing is concerned, most of the tests were done, at least the results you're seeing were coming from private labs. And even within those private labs, there was actually people who were traveling, doing international travels. They were really spending most, of the money paying for tests because of course you have to pay. You have to do a test before you travel. If you went to a government facility to do the test, it may come out after 2 months, because of all sorts of challenges within those government facilities. But I think if we look at the whole diagnostic space as far as COVID is concerned, and realize that by the time that Nigeria reported its first COVID-19 case on the 28th of February, 2020, we had only 4 molecular labs across the country, and they were all government labs. But as we speak now, we have more than 150 labs, both government, private, corporate. So you see that there's a lot of improvement in terms of diagnosis, but we know there are challenges, especially with government facilities. And COVID-19, I'm not sure how many of us that are alive today that witnessed the last pandemic, which is like 100 years ago. So we are all learning with COVID-19, but we can see that a lot really, really happened within a very short space of time, because obviously this was something that was affecting everybody at the same time, but most importantly, affecting rich countries. And that meant that, more money was pumped into it. But before I end, Abiola, I want to say something specifically about, again, looking at data. I think when we're talking about, I don't know who it was that was talking about specialized tests. Look, let's follow data. The WHO says that 80 to 90% of the healthcare needs of an individual throughout the person's lifetime can be provided at the primary healthcare level. So if we leave specialized tests and focus on those basic tests of diseases that are killing our people, a lot more people would survive. A lot more people would not live with debilitating illnesses. Abimbola spoke about tax shifting. It's ridiculous that in Nigeria, if you go to government hospitals, a nurse cannot take, or give intravenous drugs. They will tell you it's a doctor that will do that. It's ridiculous. Do you understand? And yet, when I went to Rwanda at the University of Global Health Equity, and we went into communities to understudy the community health workers, we saw them providing care that we were reserving to so-called doctors and nurses. Doctors. Do you understand? So, and this is not even considering the fact that there is a national policy on tax shifting that the federal government has approved. So until we begin to provide care at communities where people live, when at 2 a.m., if a child has fever and they are in my village in Anambra State and they cannot travel to the center, to the primary healthcare center, which by the way may not even be open at 2 a.m., how do we get community workers, community health workers living in that community to provide at least some kind of advisory, on what that mother should do before daybreak? So I'm not really concerned about specialized care for now. Those basic care, those care that we can provide at the primary health level, that WHO has said that 80 to 90% of the healthcare needs of an individual throughout that person's lifetime can be sorted at the primary healthcare level. So let's start from there, then we can now build on it. And I think that's what Abimbola, and her team are doing, really, really democratizing this. And, it's not rocket science. Let's stop, complicating issues by just reserving some kind of care or some kind of knowledge to a certain group of people, when we know that we can actually coach people, at lower levels to provide this care too.
Dr. Morris, so the other question that was here was, there is that conversation around the symbiotic relationship between the potential symbiotic relationship that we can explore extensively, and Mrs. Adebaki has spoken to that around, diagnostic centers and pharmacies, and kind of breaking down that regular model that we kind of have, and then using that data to literally inform how the private sector does quite a number of conversations there. But for some people, there is that conversation around quality. Do you think that there is going to be some form of compromise quality in this case when, like you've rightly alluded to, it's supposed to have a capitalist mindset to it, because, and there might be in certain thought frames or school of thoughts, when you begin to think about capitalism, there's always a sort of compromise of quality to certain standards, in certain regards. Do you think in that regard, in that space, there will be that compromise in quality in any way? Or do you think it's just a misconception or just a thought in the air that we're having around, lower quality, but because you want to drive price and you want to drive profit?
To be fair, I think that just like any other evolving sector, if we set at a government level, at a national and maybe subnational level, government decides that is the way to go, we will also have to experience that evolving process. And sometimes evolving process is that, they start, sometimes it's not as quality as is required, and the regulators have to be on their toes, the quality and standards needs to be monitored, and so on and so forth. But I'm not really afraid of that. Every sector in every part of the world passes through an evolving process until they get it right. My worry
Hello, I think we've lost Dr. Morris. I think we've lost Dr. Morris. Okay. Okay. So while we're waiting for, I will just have Ms. Adibaki or Dr. Ifeanyi or Lukman jump on that. Do you think there's going to be any form of
about data, and I'm going to refer to
I think
Dr. Morris, we lost you for a bit. I'm not sure we can hear you. Okay, yes, we have. Yes.
If it was me or you guys. So I'm saying that the entire system seems to be still at fault in the sense that we cannot accurately capture data, even for research purpose. Now, COVID seems to be leaving us, and we're still failing to be able to accurately deliver on the number of tests that were done. I mean, look at the discrepancies that is even coming out from this kind of conversations. And so if we're going to improve on anything, it's also going to eat into those, decisions and those approaches that we use to improve or make anything better. And those are fundamental issues. So for me, I mean, issues of data reliability is significant and a fundamental problem as far as healthcare in this part of the world is concerned. The second one I want to talk to is this symbiotic relationship. I've never heard it before, and I'm thankful that one of the panelists mentioned it. The fact that you should consider the pharmaceuticals or pharmacy to also carry out diagnosis on things, in the primary health space, things as basic as malaria. You see, where I think the problem is, just like any other problem with African government, is that because in Europe, they don't test for malaria in the pharmacies. In the pharmacy, Nigeria has not woken up to the fact that malaria is more of an African problem than an European problem. So until a German pharmacy now begins to do it and somebody travels and sees it, that's when they're likely to adopt it. So I think for us, we're still suffering the fact that we are unable to assess our problems locally and decipher the solutions, domestically. And until we get there, look at me. It's an excellent idea. We know that I can count in my lifetime, how many times I've gone to the hospital for malaria. And this is even me at my level, not to talk of, people all over that are a bit lesser. Permit me to say that. People do not go to hospitals to go and check malaria anymore. We go to the pharmacy because we know what the medicine is. Okay, they'll give us, and they'll give it to us. Why don't we just enable them to carry out the test? Why don't the government begin to think about policies to enhance the capacities or capabilities or licensing of pharmacies to carry out this basic tests at primary healthcare level? I mean, these are fundamental things and they are basic, but they are just, fragments of so many other issues that until we start localizing our problems, we will not localize the solutions. I will end it there.
Thank you so much. I just wanted to add to the conversation around quality, and Mr. Adebaki and Mr. Lukman, you can jump on this. One of the biggest problems we've seen, working as Gricd because of where we play, is around the fear that most people have with, if I buy commodities or if I do a test, am I sure about the accuracy of my test? Am I sure about the potency of the medicines I'm getting? Of course, we do know that there's that mindset, that perception of, if I don't buy my drugs from certain high-end pharmacies, or if I don't get imported drugs, so there's a quality conversation, right? And if the drugs, and for us, for instance, we do know that some vaccines and some medications thermolethal and do need to be stored in specific temperature ranges. As of today, we know there's a sort of gap in the industry, right? How can we position ourselves, within this quality space, within this conversation, to say, if I, regardless of the pharmacy I go to, regardless of the testing diagnostic center or service provider I go to, I am sure that I will get quality testing, there's minimal error, then I can get the right drugs, that in the right quality, that if I take, I'm fine, and it works for me.
I wish I can tell you that regardless of the place you go to, you will get quality. It's not yet time. Because each one of us, we need to work at it from both ends. Those of us that are providers must work on making sure all of our processes stand scrutiny and we're certified in one way, self-assessed and then externally assessed. My medicines, for example, we have ISO certification for quality regarding all of our processes. But it didn't come from someone saying you must bring a certification before we can use it. We said in ourselves, we want to build the trust index. We want people to trust. And when you get medication from us, we went through a rigorous process before it got to you. So more of us at the provider level must open ourselves up for standard quality assessment and process, integrity, so that when we then begin to say, enter any licensed clinic, enter any licensed pharmacy, enter any licensed diagnostic center, what you're getting is 100%. We're not yet there, and we should do the work that is needed to get there. But then also we need to make sure people know that, the trust that we have, that you should have in us, is valid. We have certificates to protect. You walk into any mushroom place that is selling drugs, there's no certification. There's no certificate to protect. There's no one to hold. So why don't you enter a licensed pharmacy rather than an unlicensed location? Your friend passes drugs to you, you don't know where he got it from, where it was stored, what temperature, you don't know. So that lack of clarity, that opacity, the licensed pharmacist is putting his license in line and saying, I can guarantee you that I have checked where it came from and this is genuine. So we say patronize licensed locations. But we still have a lot of work to do with cold chain integrity. We haven't quite gotten it right. Where importation distributors might be, full of integrity, but to the last mile, the way you can trace and see whether it has broken along the way, we're not able to do that right now, at least at mass, at scale. And it's still work that we need to do. We haven't yet finished it. So I can't say, with my chest, we're getting it right. But unfortunately, people think until you get to a high-end place before you get good drugs. No, it isn't so. But the pharmacies that are not high-end should position themselves to be seen as quality centers. There must be some self-regulation happening, or some, kite mark that says, I have opened myself up for these independent auditors to come to check, and they have found me all right. That's the kind of thing we're promoting. honor quality. If we can do that and get it right, then maybe more of us will be trusted.
Fantastic. Mr. Lukman?
Yeah, if I can just add on that. Earlier we were speaking about the, excuse me, we were talking about the PPP model and the role of government in delivering quality healthcare. I think this is, the standard maintenance. This is the space in which perhaps the government needs to play a strong role, right? Rather than being the gatekeeper that hinders innovation and efficiency in the healthcare space, why don't you think about how you can, ensure that pharmacies, healthcare facilities are adhering to the set standard of the individual country within which they are operating. And in Nigeria, I'm not sure who coordinates what. Obviously, you have the NMA coordinating the medical doctors, but of course, they have a role to play. However, I think this is where the government needs to play a very strong role, enforce and punish if necessary. And I think if Aaron Labs or pharmacies know the repercussions of not sticking to the standards, chances are everyone will sit up and ensure their standards are up to scratch.
We have some comments, that have been put here. So, just to read out some of those comments, it says government cannot do it all.
If I may chime in, just maybe before the comments.
Yes, please
I
go
think
on.
there's a particular area that I've not heard. I think we've not done justice to, and I'm sure Dr. Adibake has a bit of capacity around. It is the local manufacturing of drugs itself, as against importations. Statistics has it that in Africa, we lose in excess of $3 trillion on an annual basis in importation of medicines. That is pathetic for a developing continent, for a continent where we have more poor people than, average people. That is large. And the fact that local manufacturing of drugs is not being enhanced, it's not being supported, it's not being scaled, is a fundamental issue. I think the government should also look in that direction. If we're talking about, capitalizing any sector, we're talking about injecting money back that is being exported. I think it's an area to largely look at, especially given the AFCFTA guidelines now, which, loosens the trading systems. I think once that is looked at and put in place, and we're able to augment it with standardizing those medicines across, Africa, so that, there's AMA being ratified now for standardizing quality medicines. I think if the drugs will be drastically minimized in cost if good consideration is given to local manufacturing of medicine. I just wanted to chime it in since I didn't hear it.
Thank you so much.
If I may mention, okay, so investment in local production.
Go ahead.
Okay, I think one of the things that keeps NAFDAC awake at night right now is this point you just made. I don't think the DG sleeps every time she thinks about the fact that 100% of our APIs are imported. APIs are the active pharmaceutical ingredients. And that even the 30% of production relies on imported APIs. Yes. So they are doing a lot right now to encourage local production. They're trying to ban some importations so that instead of you importing certain things, come and produce it here. The more we increase our local capacity, the better. But still a long journey. Still a long, long journey. If any private sector wants to invest right now in the pharmaceutical value chain, I urge them to look upstream. So many of them want to invest in opening pharmacies. I said, that's an old problem. Go upstream and help us sort out manufacturing, even if it's not manufacturing of the capsules, the tablets, manufacturing of APIs. EMZO has a fantastic manufacturing, center site on the way to Shagamu. Yeah. We need 20 more.
Yes.
We need many more of such. We need excipients, citric acid, even the water, the pharmaceutical grade water. It must be produced. Who is focusing on the upstream leg of the pharmaceutical chain? I think that's where we need a lot of investment. And that's not social innovation, that is business.
That's
And
business.
if we invest there, we will do better. And Nigeria can be the hub to serve many sub-Saharan countries if we can, be focused and be deliberate. Over 10 years, we should have sufficiency in production of medication. Right now, we're vulnerable. COVID showed us if China and India should say they're not exporting drugs to Africa, we will go and get leaves. Tell you, we will have to start getting leaves and wondering what we should consume. So we have a dire situation, really. You've touched on it. We have a very dire situation. Anything that will lead to local production of medication, we must encourage it. The research that is needed in our own local ingredients, the processes that will make it, conducive to process medication here, the types. We don't have any suppository manufactured in Nigeria. None. You know that. And some kids cannot take medication. They must be injected through their anus. We don't manufacture suppositories here. So we have a lot to talk about. I really wish we had time, but I know,
Absolutely, Mrs. Adebaki. So like I already informed, to our participants, this is supposed to be a webinar series, and this is one of many of this, should I say, deep dives into finding how we can address the continent's problem, address Nigeria's problem, because we're speaking to Nigerians at the moment. Some of the comments we've been having, and we've been speaking, for the last more than 1 hour to Dr. Ifeanyi Sofor. We'll be speaking to Mrs. Abimbola Adebaki, Dr. Maurice Atoki, and Mr. Lukman Aru Ramimo. I'm sorry, I keep murdering your surname. I think I need to get you to pronounce it for me, then I can do it correctly. And some of the feedbacks we've gotten as comments from, so participants have said, and alluded to the fact that government cannot do it all. PPP is, one of the way out for this. Another very interesting comment here is, pharmacies have been doing exceptionally well in terms of quality of medications when it comes to vaccines and cold chain products. I remember recently I had a conversation with Association of Community Pharmacists, and they were telling me that they were looking to partner with development organizations to see how they too can play within that value chain, or more actually within the value chain of providing vaccines, because they are actually already there. They are literally at the community gates. It's just the same way we had the issue of maternal health, and when maternal health community or a traditional birth attendant that kind of obscure. And I remember one of the biggest challenges that medical practitioners had when Dr. Shelton talked about how do you use traditional birth attendants within the setting. But literature and our regular knowledge over the years would not allow us embrace it extensively. But we do know that the skill sets somewhat exist. How do we then use that innovation within our locality and our context to be able to address some of our challenges? I know that 2 hours, 3 hours, even 5 hours is not going to be enough for us to extensively trash this topic. We look to be able to have more of this series and invite you back and to speak about this. We're looking to be able to make this a continuous series and have different aspects of the healthcare really being trashed and being talked about. And we look forward to having you and quite a number of other colleagues working in the healthcare space. And like Dr. Morris has already said, because in business, we need to bring other people. Let investors tell us, why are they not interested Africa's healthcare system. What are the practical steps that would get us to be able to attract that investment? Because in itself, health is a business, and like we rightly said, there's a quality aspect to it. And if we trash the issue of quality, then there's that concept of trust to elevate people, because they already are paying for suboptimal care already. So when there's quality standards that are there they are then able to say, well, happy to connect to that. It's been quite an interesting time engaging with everyone today. It's been almost 2 hours of very high level, wonderful engagement. Thank you, Dr. Ifeanyi. I would just over the mic to Gricd CEO Tega your team to just kind of give us a closing remark and kind of do a little bit of farewell. Thank you.
Thank you. Thank you very much, Abiola. And thanks to all our remarkable speakers who joined us today. I know you guys are incredibly busy. Thank you so much for this opportunity. It was a really insightful session. I followed through, and thank you so much for honoring our invitation today. We wish we could pay you back, but unfortunately we can't. But thank you again. Thank you very much to everyone who's joined the session. We hope to have many more of these sort of sessions. And to our panelists, thank you very much. Hopefully we would have you on more of these sessions to share, this amazing wisdom which we've learned today. So thank you very much.
So participants and to all the people, we will be posting the videos and interactions of this session today. We'll be posting it on our links and we will share with you. We look forward to having you more, and thank you, and do have a wonderful evening. Bye for now.
Hi, my name is Diagnostics, and I'm the founder and CEO at Gricd. Recently, we started some work with the National Primary Healthcare Development Agency, where we were able to help them track the 4.2 million doses of the Moderna vaccines being given to the Nigerian government through the COVAX facility from the United States of America. The importance of the work we were doing was to ensure that vaccines being delivered to the states were being delivered under the right conditions. And also, if there were any excursions, we were going to advise each state on what the next step to take was. And basically what we were doing was we issued data loggers, real-time data loggers, which we call the modes. They are put inside each of the boxes that are being transported to every state. And then we're able to monitor each of the boxes in an entire batch as they're being transported from one place to another, monitoring information such as the temperature, the moisture levels, as well as the location of the vaccine per time. While the vaccines were on the road or in the air, we were able to monitor them using the enterprise software, which we give to our customers to interact with their hardware products. And on that platform, you're able to monitor in real time the location, moisture levels, as well as temperature conditions of the products that are being transported. But beyond that, you're also able to create like alarms for excursions, meaning if a threshold is exceeded, then it could send a notification and SMS alert to respective parties, advising them on what next or what step to take to ensure that the vaccine isn't lost. Beyond that, we're also able to calculate things like rate of change, MKT on the platform to ensure that the vaccines that are being distributed are in best conditions And if there are any issues, these individuals are advised, or individuals on the state level are advised on what next step to take to ensure that, they get the best out of it, of what they receive. The moat and the software technology are relevant to a lot of other sectors which we've seen, but particularly for healthcare and agriculture. The products today are not just used for vaccine distribution, but there are applications in other distributions, such as sample that's being collected from the last mile being transported to the laboratories, organ transfer, and even in agriculture, we've seen applications such as warehouse storage monitoring, the day-old chicks temperature monitoring as well, because they're also all these products are very sensitive to temperature, humidity, as well as you want to know where their locations in case of theft or things like that. I think the Nigerian government demonstrated high level of quality assurance by making use of a real-time monitoring system. They could have made use of a data logger, which would probably be like an after-the-fact type of technology where, when the products land, then you can read the temperature, but by that time, things may have gone wrong. But with the real-time monitoring system, they were able to see, products where they were at every point in time. They were also able to see what the storage conditions were. And with this, they were able to advise each state on what next step to take, and they demonstrated high levels of professionalism, both on the federal and both on the state level, to ensure that the products that were being delivered are, were in top-notch quality at the end of the day. I think I would advise that as many people as possible take, the vaccines, because once you have one person unvaccinated, then you have a breeding ground for another variant, which may be worse than the Delta variant. So the faster we're able to, immunize more people, I think the faster we're able to kind of draw a curtain on this whole horrible pandemic that is ongoing.